I start Zoom, it's always a disaster.
We are now streaming silence on YouTube.
Yeah, exactly. Streaming silence, which is certainly the best we can. Well, so the disaster is away. So now I start the webinar. One minute to go.
He's here.
Very good. Well, I suggest we start, and I want to welcome everybody to attend this Committee of Expertise. We are going to address a couple of very interesting things on the topic IDMP, Semantic Specifications for eHealth Services. That is in the context of UNICOM, one of the deliverable of the work package 5, which is addressing this, and that document has been finalized recently, and the purpose is here to highlight some aspect of this subject. We have 5 speakers who are listed here, but I'm going to present them a bit later. We have some rules for such virtual meetings. I saw the list of the participants. Many of you have been already attending Committee for Expertise, but nevertheless, it's important to remember us that you are on mute, the participant, you are on mute, the speaker are on mute, except the one who is speaking. The participants are invited to post their questions in the Q&A facility. I'm going to show you how that works. It happens that we give the microphone to participants, but also, of course, speaker and panelists will be able to speak in the debate after the presentations. So we ask them to be concise so that many can speak. And for the participants, you can also use the possibility to show your approval by clicking on the button. I will show you in a minute. We have this Q&A facility, which we encourage you to use. And activating this is relatively easy. You move your mouse on the screen, and you see then a bar appearing usually on the bottom of the screen where you have Q&A on it. And when you click on that, you see you have the possibility here to type your question. Once done, you send the question. And that will be queued in the folder All Questions. The other participants may show their approval by clicking on the hands, thumb up here. And this will show the panelists and the speakers your question or that question higher in ranking. And that's a possibility, especially if you have several questions pending. For those who ask the question, once it is responded, you can find it back in the folder My Question. For the others, it will disappear for the panelists, they can still activate that question and add perhaps some text in it. We don't exclude that questions are answered during the speeches. Sometimes there are very specific questions and it is just worth to answer immediately. Some others will be kept for the conversation we have at the end of this webinar. This webinar is recorded. It is also protected by a password. You have received your personal link to join. It is broadcasted on YouTube, so for those who may not be able to join on Zoom, they can follow what we are going to say and exchange on this YouTube channel mentioned here. And of course, for those who were not able to join today, they can find that back in this channel. At the end of the session, we will have a questionnaire popping up, I mean the hyperlink for that questionnaire popping up. But also after this meeting, you will receive, namely tomorrow, an email from Zoom inviting you to answer a few questions, various few questions on this online questionnaire so that we can understand the feedback in terms of quality, etc. Well, we have today not less than 5 speakers and 2 panelists. Let me introduce you to them. We have the first is Anderson Carmo. He is an eHealth project manager at SPMS, that is a part of the Ministry of Health in Portugal. We have José Teixeira. José is a healthcare IT expert. He's very much engaged in data and standardization in various standardization bodies. And he's also engaged in UNICOM work packages, as well as Anderson, who is the co-leader of the work package number 5. Robert van der Stichele is a physician. He is retired professor at University Gent. He is our academic reference in UNICOM for several things. Robert is working for IHD and also is engaged, as I said, in UNICOM work package 1 and other work packages as well. Frederick Bilken is an EHDSI business and functional analyst, and he is also change manager in EHDSI. Last of the speaker is Matthias Gies. I don't know if you say Gies or Gies. In German, you may say Ü for Y. But Matthias, he is EHDSI solution provider, developer, and has a role in the definition and visualization of clinical documents for cross-border exchanges. 2 panelists. The panelists have the role to ask and answer questions. Also, Marcello Melgara, he is EC project reviewer and evaluator at LISPA in Lombardia. And Jean-Gonzague Fontaine, he is a product and substance master data lead at GSK Vaccine. He is a very known IDMP expert engaged in ISO working group 6 or TC215 working group 6, where he's working intensively in the space of substances, especially. Well, these are the people who are going to tell us everything about the semantics across the life cycle of this medicinal product. As I said, please use the Q&A facility, and for the feedback, you will please also use this form. Again, the hyperlink will be sent to you with a thank you email after this webinar. Now I want to give the floor to Anderson, and he will explain us everything about this. Thank you.
Okay. Thank you, Christian, for the introduction. Thank you so much for attending this seminar. I would like to present the first slides, please, the next one, about the introduction and scope of the semantic interoperability and how we are working in UNICOM towards this common objective, not just to implement the IDMP in the eHealth services, but also in other stakeholders that together can issue the prescriptions and other points and try to make this part more interoperable. Next slide, please. When you see all the data that are related with the medicines, we have a huge amount of data related to description of the medicines, and depending of each process of the life cycle of this medicine are represented different amounts of data that should be represented. So if you think about the registration, we have the full quantity of data, the most quantity of data related to this medicinal product, until the use cases as a dispensing and prescribing. So different phases and different purposes of the life cycle of the medicine should have description of different amounts of data that can be one analogy as a mountain. So in the base of the mountain, we have the most quantity of the data, and the lower quantity of data that are needed to represent this product in a safe and unambiguous way. However, next slide, please. When we talk about the M implementation, the Article 57, we have a little bit of problems because it's a bit more bureaucratic way to represent this data and to use it. So it looks like we have not the capacity to use this kind of data, and so we need to have more. Has become a gap between these points. However, in the introduction, next slide, please. However, with the introduction of the ISO IDMP standards and implementation in the different stakeholders in the health sector, we can try to solve this problem. Of course, ISO IDMP will not solve all the problems, but it can, of course, improve the current system and try to let this data that you are representing the medicines and other perspectives in a general way that you should be used. Next slide, please. So when you talk about the semantic interoperability, it's basically consists that all the data, all the meaning of this data be the same across the exchanges between the countries, between the systems and other points. So we try to ensure that all the data, all the meaning are consistent and unambiguous. So we can say that the meaning of the data elements shall be clear, unambiguous, and shared between the parties. And also, when the data is coded, the values and their meaning shall be also shared between the parties. So we try to always, when you use semantic interoperability, use catalogs, code systems, and value sets to represent this information in different languages, in different contexts, but the information, the meaning of the information that is main important, keep the same between the countries, the other points. So this is the overview about semantic interoperability that you try to implement, to use it together with the ISO IDMP in order to achieve the same goal. Next slide, please. When you talk in semantic interoperability in the light of the UNICOM project in general, we have 3 key enablers for semantic interoperability. The first of all, is the IDMP specifications that are set of ISO that I will explain a little bit after. The MS part that is regulator part and they provide the data and regulate this point. And EHSI that is a solution provider, and so they manage the prescriptions, patient summary, in all cross-border exchange of data, of health data currently. So those 3 enablers together support the semantic interoperability. And in UNICOM, we try to implement the ISO IDMP together in the 2 other stakeholders in order to achieve this point. Next slide, please. So when you talk about the concept of the ISO IDMP, is basically on standards of 5 ISO standards and specifications to represent the medicinal products as the best way as possible. Inside the ISO specifications, we can also achieve 3 different identifiers from the IDMP identifiers as the PHPID, MPID, PCID. The difference between this is basically the level of the details that you have. So PHPID is a generic prescription, the generic description of the medicine. MPID is a bit more specific because it's linked with the market authorization holder, and PCID a little bit more specific with a box level. So these three identifiers can also support the identification of the medicines in medium and long term. However, currently those identifiers are not available, and we work a lot towards the attributes and other elements that describe the medicinal products. Next slide, please. Other enabler is the MSPOR database that is contains information about substance, products, organizations, and referential. So all the use of the SPOR portal can provide to the users many data managements that is very important to highlight to regulators purpose and also to services purpose also. And the last enabler, next slide please, that you're talking about is basically the EHSI, that through the EHSI today we are able to issue prescriptions in different countries using a simple schematic. So the clinical documents in the country of affiliation, the country of the patients have the affiliation are presented in common formats, and this common format of the national use case can be transformed and exchanged in pivot documents that are common formats that all the countries that are inside of the HSI structure can access this document. And then this document can also be transformed again in the country B, the country of the treatment or the dispensation of the medicines in the case, in national content. So the information from the country A is basically the country B that will access the information from country B will receive the same information independently of the language of the country of affiliation and the language of the country of the treatment, even the original formats of the documents. Because through the EHSI infrastructure and the NCP eHealth infrastructure from the country A and country B, this document passed for a national format, for a common format in the pivot format, to be transformed and translated to a second country that they are in use. So these three enablers together, they are specifying how we can use this point. Next slide, please. So the main scope of the work of the work packet 5 and also the deliverables in this work packet in UNICOM is basically to adopt the IDMP standards in the national and the cross-border systems in order to ensure the semantic interoperability between the services that you are talking about, mainly from e-prescription, dispensation, and patient summary. So through the UNICOM, we can also define a minimal semantic data set that can be used and shared by between the different countries that are on board in the project and for other projects in order to have the same language, the same concept since the beginning. Also to determine the terminology systems and value sets for each element and the minimal data set in line with the HSI. So it's basically take the information from the ISO IDMP and the UNICOM projects and be in line with the EHSI data elements and other points in order to have this correspondence, direct correspondence between the data, meaning and the other points, and also to map the national medicinal products to the IDMP codes of the minimal data set. So the idea is try to really to align all the attributes related to the medicinal product and do the correct mapping and association with the HSI in the national context in order to ensure that all the data will be related and also interoperable. So the meaning from the country A will be the same meaning from the country B, even if there are the different systems in different languages. Next slide, please. And so just to finalize, as I demonstrated, there's a talk a little bit before. So all the IDMP definitions There are many of they are really needed to use from the eHealth services. However, so the IDMP identifiers, the definitions, and also the sport value sets, they are associated with them because the sport database, the value sets are already in the ISO IDMP formats. They will be linked and associated directly with the EHSI definitions and EHSI master value set catalogs. So when you combine those two informations, we can have the product data and the treatment data for the three services different. And so they will require basically the same information that needs to be required to the issue prescriptions and dispensations, of course. And the correspondences between the IDMP definitions and value sets and the EHSI value sets can be managed and mapped in order to achieve this semantic interoperability related to the medicinal product data. This is basically the overview that I would like to contribute to you. Next slide, please. Now, I would like to invite José Teixeira to speak a little bit more about semantic interoperability. Thank you so much.
Hi, thank you, Anderson. I hope you can hear me well. So yeah, let's move on from here. So I would actually start with what you just mentioned in this last slide, because that's also the slide that I would like to wrap up with. Roughly. So we have seen what is the purpose behind our semantic specifications. So let's see what those are, or how do we see them, and let's explore a bit from there. So semantic specification can be seen as the clear and unambiguous definition of what information is being exchanged and what form it is expected to take. It's not the same as a technical format. So we are looking at defining the data, not defining how the data is being transmitted. And here's some examples of semantic specifications. So when we talk about a product, we can mean a lot of things. But if we talk about a prescribed product, we are being more specific about what we mean. Same thing when we talk about an identifier. If we talk about an identifier versus a product identifier, we are being more specific. And if you talk about an IDMP product identifier, then we're being even more specific. So this is specifying the actual meaning of the data. That's one key aspect of our semantic specifications. And we also include the vocabulary options where available. So this is also part of our work, is when we talk about those form, well, we talk about EDQM those form or the sport those form. That's the kind of exercise that we go through to make sure that our semantic meaning is very specific and clear and unambiguous. Next slide, please. So just a quick confirmation of the difference between this and the technical format. It's normal that we sometimes mix them both. The semantic specifications, they sit one level higher than the technical specifications. So the technical specifications, it's just a syntax, or it's normally a syntax on how to present the data. We can say it's JSON, XML, anything else. But the technical specifications also contain the semantic specification embedded within. So, for example, if we have a technical format, it's common that we see that the patient has an optional gender which has these possible values, male, female, and on another. This is a common part of it, so it's a normal part of a technical specification. It does mean, so it has some semantic meaning when we say that. So the patient has an optional gender, so has a gender attribute, which is optional and has possible values. So we are kind of implying a semantic meaning to this. And this is why many times when we look at the technical specification, we can infer or we can guess the semantic specification of this. But that doesn't always correspond to the truth, or maybe that inference or that correspondence does not match. So, on the other side, a technical specification does not define what the data. So, for example, if I look at gender, male, female, and on another, I do not know if this is administrative gender or if it's gender identity of the patient. And that is something that from the technical specification alone, we cannot guess it. So that's when we need the specification, the semantic specifications to be in place. And another thing that we have to take into account in the technical specifications is that they also introduce a lot of information. So as a consequence of this, what we have when we look at the technical specification, there's one good thing that happens, which is, oh, I see what the data means now because I look at the technical specification. So there's lots of meaning in there, but also there's a lot of technical specification. And one of the advantages of having semantic specifications is that you should not have to be a technical expert to understand what the data means. And this is a problem that is plaguing several parts of several projects. So if you go to the next slide, please. I would like to explore a bit on that. So just for some context, I will mention the context behind the data. What happens typically in large projects, and UNICOM is a very large project, is that what is relevant in one context might not be in another context. So when we talk about product code or indication for prescription, well, if I'm talking to someone in the prescribing universe, those mean something. If I'm talking to someone in the regulatory universe, that might mean something completely different. So also what rules apply and codes are expected, they will also different. So what are the codes for substances that we use, and many other examples. So the context for how the information is intended to be used, that is very important, and that changes across the different realms of application. And that's also a pain point that we've seen in projects. So if you go to the next slide, please. UNICOM does show this when we have different parts of the project that have to handle with data specifications, and we say this is the value set. No, that is the value set. No, this is the cardinality, and that is those differences, they always exist unless we start documenting and capturing our semantic specifications. So the questions that we want to answer when semantic specifications are formalized is basically it becomes it's to address those points, like, can we share the data elements across the data flow? So from prescription to regulatory to pharmacovigilance, can we share the data element? I would say we can if the data has the same meaning, because even if it's in the same format, if it doesn't have the same meaning and the same conditions, we should be really careful about reusing the data. And this is one of the biggest issues in UNICOM and practically all big projects. So another thing is how sound is our implementation. So how solid is our system that if we need to change one data element or to revise something or to add a different component to the architecture, how well is this going to handle? And this is also a fundamental aspect, and knowing that is also a fundamental aspect, because, for example, as you've seen in UNICOM, once things start being designed in the regulatory universe or in the clinical workflows universe, then we take some assumptions. We assume some semantics there, but how sound is it to go and extend that to other places? And that is one of the problems that we've been handling. And I would say less important, how can we change the technical format between specifications? So how can we migrate between CDA and FHIR, or between XML and another version of FHIR, or how can we manage between different versions of the same technical standard like FHIR? Are those things even supposed to be compatible? Well, if we don't have our specifications documented, that would be harder. Next slide, please. So for the scope of semantic specifications, so just to make it a bit more concrete, it's pretty much comes down to say, well, we have a data structure. So we have data structures, we have our data objects, and in there we have data elements that have a name and definition and some rules. And we have, for example, we have cardinal, and by rules I mean the optionality and cardinality that the data elements have, the value sets that it's supposed to be conformant to, and any other rules like this rule, this element excludes the other element, etc. And if we start documenting this, then we are at a much better chance to have we are actually documenting our semantic specifications. And that's pretty much the purpose, is to define our data elements independently of the technical format how it's going to be used or exchanged. Next slide, please. So our process has been pretty straightforward, which is identify the contexts where the specification applies, because most of all, context does matter. And then we identify what is really relevant in or across those contexts. For example, we don't have to replicate the entire regulatory universe in the clinical workflow universe. However, what we do inherit should be semantically consistent with what is defined in in the regulatory realm. Otherwise, we are introducing data distortion. And then we identify gaps, overlaps, and misalignments. For example, if we have a value set that is used in one part of the system, so let's say in the HDSI specifications, we have some value sets, and in the national competent authorities, we have other value sets that we expect. And if in the regulatory universe, we have the another set of value sets, then it's the normal thing to do is to make it manageable, is to identify those gaps and where this overlaps and any misalignments. And we do this always by formalizing the data definitions, not the technical format, the data definitions. And next slide, please. So this is just a rough indication of some of the contexts that we had to look into, and this is kind of data flow. So we know that the substance they would be typically provided, so defined by the EMA in terms of value sets, the organizations as well, the products and their definitions, and a couple of referentials that we saw reference data that we have there, and that goes into the WHO for maybe some IDM, sort of some PHP ID generation, where they also maintain the ATC categories as a value set. We also have ISO that defines the standard, and that provides the definitions. And then we have the NCAs that have to use all of that data. So we still had to look at all of those. And next slide, please. And what we did is to very simple, this picture just tries to demonstrate that we look at those, we identify the data elements, and this diagram just basically means the blue things are data elements and the purple things are the value sets that can be associated with some of them. And after doing some mapping, and that's actually the next slide there. Oh, sorry. So I just mentioned this so we can skip to gain some time. Oh, the next slide. Yeah. The picture that Anderson was showing, this shows up as now as a table in our deliverable, where we see this is the definition of the element. This is what it means, and this is the value set that we have. And whenever we encounter gaps in the definition or in the rules or in the cardinality, then we made some recommendations for the target semantic specifications. So the idea is to, out of this, we say from all these gaps and overlaps, we identify this need to correct this. We need to identify, for example, a common substance value set, etc. And I would so this has been pretty much the scope of our work. And I would just wrap up by saying, if we do by doing this in a formal way, or trying to do this without let's say not just based on best effort or intuition or current feeling of how things should be done, then we make the specifications actually manageable, which means that if today we miss something, then it's okay. Tomorrow we can always revise it. And having formal specifications makes them manageable. And it means that we don't need to have always the same experts at the table, which is essential for UNICOM to roll out, because then we will need to have many experts in many countries, and they have to have a solid reference without asking the opinions of all the different people, because as we've seen, if you ask a common opinion in one context, you might have a different opinion that if you ask in another context. So this is why it's so fundamental to have those specifications structured, governed, maybe with a process behind it. That's the next thing to discuss maybe. But for now, I would just like to leave with this. This has been the outcome of our analysis. We looked at the essential things and looking at the prescription in the dispensing the HDSI data set, looking at the elements that we had in IDMP. We came up with these attributes and we identified the specifications for that. I'm sorry for being a bit over time. Thank you very much.
Thank you, José. I was supposing that you would give us the receipt to implement this.
I am not a good pizzaiolo, but yeah, I did not contribute with this, but I can talk to this if no one else is stepping in.
Okay, so thank you, José. Now we have here the chance to move to the next presentation, which is made by Robert van der Stichele. He's going to speak us about the medicinal product dictionary and its role in this. Robert.
Thank you, Christian, for the invitation and also the request to see and to analyze what could be the role of the medicinal product dictionary in all of this. Medicinal product dictionary, which we consider a little bit to be the bridge between the regulatory world on one side and the clinical world on the other side. We know that in each country, there is at least 1 to 4, maybe sometimes more, medicinal product dictionaries available. And all these dictionaries provide textual information and data on 4,000 to 15,000 medicinal product packs in each of the 27 member states. If we take the average of 8,000 medicinal product packs, then that means 27 times 8,000 medicinal product packs. And because they keep that information, not only from the regulatory point of view, but also from the clinical point of view, on all these products, I think they are a very valuable stakeholder at the national level and need to be reckoned with and integrated. UNICOM Work Package 9 has developed several surveys of these MPDs and descriptions, different models of medicinal product dictionaries, and it's really worth to read. Next slide. Next slide. Yeah. Before we enter into discussion of what the role of the medicinal product dictionary is, I like to reflect shortly about the differences between master data and reference data, as was highlighted in deliverable 5.4, which we are discussing today. And I think that's an important concept and needs to be considered here. Reference data are data on terminologies. They are value sets and codes of terminologies. They are mostly held by the S and R part of SPOR, S for substance and R for referential. They are also held by the eHSDI master value set catalog, at least for substance and for dose form. And for substance, they would contain the SMS code plus the label. And for dose form, the IDQM code plus label in 24 official languages. And that is what we mean when we talk about reference data. It is expected that it will be soon available, and the source of it are respected existing sources, just like EUSRS, who has done the data cleansing on substances, IDQM, well-respected directorate, and the Regenstrief Institute for UCOM. Master data, on the other hand, are data on actual medicinal products. Those will be held in the P of SPOR, the P of product, for the whole of Europe, for 27 member states. But they may not be available anytime soon, and in my opinion, will require some cooperation at the national level. Next slide. To understand what we are going to meet in the future, it's important to make a distinction between procedures for new products and otherwise procedures for the legacy conversion of older products. If we take an index day, which can be today or next year or in 2 years, when at a certain moment the industry will start submitting authorizations in IDMP compliant format to EMA, which is the scope of the DADI project, then the prospective realm of IDMP will start for the new products. They will provide an IDMP compliant registration, and the data will flow from EMA to the national agency, to the medicinal product, and then a dictionary, and then from the dictionary to the vendor, and from the vendor into clinical care. That's the picture for the future. But of course, we have a big legacy conversion in each country, about 8,000 product packs already on the market, where it's not always clear what the substances need to be defined. Those forms described in the country are not all yet standardized to IDQM, and strength needs to be normalized. And in order to be able to do that, we must engage sometimes for the older products in discipline, which I would call pharmacoarchaeology. So it's a really different and a difficult process. Next slide. When we engage in IDMP standardization at the national level, there are a few crucial questions. How soon will the reference data be available at the national level? Will the spore substance and data and referentials, dose form, substance data and dose form, will that be available soon for the NCAs, but also for other stakeholders at the national level? Will the EHSDI master value set draw data from spore and make them then available to the national contact points, but maybe also to other stakeholders? And who will make the master data in the medicinal product in legacy conversion? Will EMA EMA be able to create the master data for 27 times 8,000 products? Will EMA and the national competent authorities of each country reach some kind of agreement on the division of work? And will the NCAs cooperate with the medicinal product dictionaries and other national stakeholders to accomplish this massive task, which should not be underestimated, country by country? And in that way, also in the legacy conversion, reliable IDMP data could flow in the direction from the NCA to EMA spore and to result then in a final stable solution and the resolution of the legacy conversion. Next slide. If we want to do this legacy conversion, there are some critical tasks for IDMP standardization at the national level. Answers that need to be provided for each of the national medicinal product in legacy conversion from 27 times 8,000 medicinal products. For the substance, does a modifier needs to be defined for the moiety, the active moiety of the product? For instance, amlodipine, do we have to define whether it's basilat, mesalat, or maleat? If yes, which modifier for that product? Is it basilat? Is it maleat? Is it the other one? And what is the substance code for the substance with the role of the precise active ingredient? That's a whole lot of work. Then for the dose form, we need to define for each product what the correct ADQM term and code is for this local dose form. And with that comes then the whole range of attributes that is attached to the ADQM term. And finally, for the strength, we need to know on what the official authorized strength is based, on the moiety plus the modifier, or on a reference product. And to answer these questions, and then which could fill most of the 17 variables of the minimal data set, it's still a hell of a job. Next slide. Why would MPDs, the local national MPDs, be motivated to engage in this? Well, I think they have on their own a willingness to improve the quality of internal data and also to align their own systems with the IDMP standards. They are interested in international cooperation, and IDMP will facilitate that. Most of them are interested to invest in a good relationship with their national competent authority. And some of them have the desire to be an intermediary between the agency, the eHealth system in the country, and the vendors in the country. And also a little bit the ambition to produce minimal data sets for cross-border pilots if the local NCA is not able or willing to provide them on short notice according to the calendar of the waves of the e-prescription introduction. Next slide. So the mission of the medicinal product dictionary could be to be a key player between the stakeholders at the national level, and and we name them here: the national competent authority, the eHealth system, the electronic health vendors, the national contact point for cross-border prescriptions and dispensing. And I would call all these stakeholders the intra-national drug information providing ecosystem, and do it in such a way that it also profits from, but also to, the supranational ecosystem, which is composed of the pharma headquarters, who take the basic information on their drugs in the different countries, the EMA, the heads of medicines agencies, and then the eHealth digital infrastructure. And that I would call the supranational drug information providing ecosystem. And next slide. We have seen this picture on the left before, the supranational ecosystem with the pharma, with EMA, with the NCAs and the eHealth infrastructure, together cooking up IDMP standardization. And it's thanks for Marcello for this picture. And we added another picture for the intranational ecosystem, where the national contact point, the agency, the eHealth system, the dictionary, the vendors, and for the doctors and the pharmacists should all cooperate, not to approve products, but to validate the IDMP standardization, and at least provide validation that the IDMP standardization also works in the clinical system. And so my next slide is the last slide and the conclusion. Collaboration between the stakeholders at the supranational ecosystem and at the international ecosystem is probably the key to success in IDMP implementation. Thank you for your attention.
Thank you, Robert, for this overview of the role of the medicinal dictionary. I suppose it has been enlightening for many of our attendants. Maybe it's also good that I just mentioned here that UNICOM Work Package 1 is currently working on a demonstrator where we will see a couple of processes supported by the various actors, including the medicinal product dictionaries in the prescription dispensation processes. It's highly interesting, and we will certainly have a community of expertise about that in a couple of months. Now it's time to share the floor with our colleagues from the European Commission. I think the first speaker will be Matthias, correct?
Thank you very much, Christian. I think I will start. Frédéric Vulcan speaking.
Yes.
As a business analyst, functional analyst, change manager of the solution provider team of EAGSI, my help at EU. We can go on the following slide. So we first wanted to start with a generic picture of IDMP showing again how MPID, the medicinal product identifier, encompass the PHPID, the pharmaceutical product identifier, which itself encompass the notions of substances, of dose forms, of units of measurements. The PCID is not present on the picture, but it would encompass the full picture, as it would encompass the full package. We can go on the following slide. So on the implementation level in EAGSI, in my help at EU, any new evolution starts with a change proposal redacted by working groups such as the semantic work group, the technical work groups, the semantic architectural work group, or the requirements work group. And specifically for the ISO IDMP topics, we received two change proposals, CP63 and CP66. CP63 regarding the improvement of the medication information representation, and CP66, the preparation of the requirements catalog, which is the documents, normative artifacts encompassing all of the requirements of the EAGSI behavior. And so for ISO IDMP. So we see that, for example, CP63, it was proposed by the STF architecture work group. And for this change proposal, we received 6 positive assessments from the different member states. And for CP66, which was proposed by an aggregation of different work groups, the EP cluster, the semantic work group, and the STF architecture work group, we received 7 positive assessments from the member states to implement it in EAGSI. For a target for wave 6, which means actually this year, so for the requirements catalog release for April 2022, and for the technical specifications release for May 2022. with the first test of ISO IDMP identifiers exchange planned for the preliminary test event for October and for the formal and upgrade test event for March of next year, 2023. We can continue on the next slide. So more specifically on the requirements catalog, we still have 2 possible open points, but it is more actually addressed by the semantic work group. And I think you have already decided what we would do for wave 6. But the 2 points of interest, I should rather say, is or are the use of the reference strength, which is to allow the definition of a strength based on the strength of a referential substance, which is already part of the ISO IDMP standards and already used in the EMA data structure. And we know that at national level, Sweden already use the concept of reference strength, and that Finland would plan to use it. And the units of presentations, which is actually the possible use of discrete units, such as the number of tablets, the number of syringes, to complete the already available units of containers, such as the milliliter and the milligram. We can continue with the next slide. And so, in parallel with the definition of the requirements for ISO IDMP in the requirements catalog, the eHealth network has also developed the guidelines for the e-prescription V3 for a plan released for June of this year, 2022. With the definition of the different identifiers of ISO IDMP, MPID, PHPID, PCID, as displayed on this slide. And basically, for the implementation in the catalog, we already used the draft version of the EP guideline V3. And on the other side, we also performed several reviews of the EP guideline V3 to ensure that it was also aligned with actually what was planned with the requirements catalog of EHGSI for F6. And we can continue with the next slide. And I will let Matthias continue.
Hello, good afternoon. So as Frederick already explained, we based ourselves on the eHealth Network Guidelines version 3 for e-prescription, the draft version. And based on the guidelines that were defined there and the data elements, our requirement catalog was updated for wave 6, so planned to go in production for next year. And here on the left on the screen, you see an extract of our requirements catalog. And here you see it, for example, for the prescription clinical data. You see that a medicinal product description contains different data elements, for which one is the medicinal product identifier, and another one is the medicinal product classification. On the right of the screen, if you go one step further, you will see the link appearing. Yes, so here you see that the medicinal product identifier, what is actually on the right of the screen is exactly this data set from the requirements catalog. This model is actually loaded in RDecor, and RDecor is our template management tool. So actually everything which is defined in the requirements catalog is copied, and the full hierarchical structure is available in RDecor, which is the tool for the template definitions. And like this, it's supposed to be very clear that what components in our CDA documents are representing what data elements. So next slide, please. So here you see on the left, again, we have the same structure for the e-prescription. So what's for us of very much importance is like the medicinal product. In the requirements catalog, we described like the medicinal product identifier and also the medicinal product classification. Apart from this, we also have the product identifier, the package identifier, which is the PCID, which was already presented. If you go one step further, you will see the linkage. So on the right, we have the CDA template definitions. So this is a specific template definition to represent the manufactured material for the medicinal product. So as you see, this is already maybe too technical, but it's just to see the linkage that we really did the implementation. And what we saw in previous waves is that the code on the manufactured material level was often misused by member states. Like sometimes they were putting the medicinal product identifier as is supposed to be, but sometimes they were also putting the package identifier on that location. So what we do now is we have this very clear linkage. So the hierarchical structure on the left is actually represented also in the template definition. So the linkage, you can see very clearly that what elements from the requirements are actually located where in the CDA template definitions for e-prescription and also for patient summary, of course. So next slide, please. Here you see then the implementation of the templates. So it's we are using for EHDSI as a solution provider. For the moment, we use CDA. So this is like an XML-based structure. And we also use the pharmacy extension. So here you see very clearly, if you go further one step, here you see very clearly the different elements. So here you see at the code level of the manufactured material, the code which is supposed to contain the medicinal product identifier. If you go one step further, you have the package identifier, which is defined on the container packaged medicine level. And if you go then one step further, we are able to represent the PHP ID. And just very important to know that this will be available to be exchanged cross-border from next year on. So this is just the document format. So, and it's only optional. So if member states for now don't have a PHP ID or they don't have a PCID, they don't need to pass it. But if they have it or their national agencies are able to provide it, they can exchange it cross-border. So this is what's important for Wave 6. Next slide, please. Apart from this, technical implementation for defining the documents, we also did some work, as was mentioned already before, on the value set level, which is the master value sets catalog, which is used. And for now, for Wave 5, we're already using 3 different value sets. First one is the EHDSI dose form, which is based on concept from EDQM. Again, on EDQM, we have also the EHDSI route of administration and the EHDSI packaged value sets. And those concepts are already related and closely linked with the UNICOM project and IDMP. And for the next wave, so for Wave 6, again, for operations next year and for member states to implement this year and to test towards the end of the year, we also foresee 2 more value sets. First one is the quantity units, also from EDQM, and also a value set on the substance. And this substance value set is supposed to contain concepts from the EMA SMS list of substances. Next slide, please. So here, still this work will be done and will be released towards the end of next week. So the first release candidate for our Wave 6 artifacts is being prepared currently. And work that still needs to be done is on one side, we have a reference implementation of the CDA display tool. So we also need to think about a way to display the different identifiers like the MPID, PCID, and PHP ID. And also the ongoing topic like the units of presentation, as Frederick already mentioned, are currently ongoing, and the activities are tackled in different working groups. First is the requirements work group. So they define the requirements based on the guidelines and also on other bases. Then we have 2 semantic task force work groups. One is the architecture work group, where currently the architecture is defined for the CDA template definitions. And also we have the normal semantic task force work group, and there is more the ongoing discussions on the different value sets in the master value set catalog. And of course, because the different topics also involve the EP cluster, they also handle these topics because they are managing all the aspects related with the cross-border exchange of electronic prescriptions. So that's it. Thank you very much.
Thank you, Matthias, and thank you also, Frederick, and all the other presenter. We have now, you are precise like a Swiss watch, by the way. because it is exactly the top of the arrow. And it was the time we defined as the start for discussion. For our participants, we recommend them to use the Q&A facility, and we will lead the conversation based on that. But perhaps we can ask our panelists if they have comments first. And for that also, I would suggest that all the speaker and panelists put their camera on, so everybody can see everybody. And yet, if one panelist would have question.
Sorry, my camera is disabled, Marcello.
Yeah, you are not the only one. We have 2 disabled cameras, but that doesn't mean you cannot ask a question or make a comment. Right? Who can I give the floor first?
So if you like, I can start, but without the camera.
Yeah, please.
Okay, so thank you very much to all of you, not just for today, but for all what it has been done jointly, because this is a practical demonstration on how things can be created together, meaning we started some time ago, Epsos time, for those who participated with the previous project on cross-border interoperability, and we learned that there were issues. Then there was another project called Open Medicine, and we continue having the same signal. Then UNICOM project was started, and we started having a solution working all together between the member states, National Competent Authority for Drugs and for eHealth, in cooperation with EMA and others. And now, today, it's a practical demonstration on how we are cooperating with the MyHealth at EU in order to transform the concept and the idea that were started, of course, by standard bodies with IDMP, elaborated in UNICOM, and now put in place as Frederic and Mattia are showing in the reality of real operation. Because remember that it was not highlighted enough. MyHealth at EU, the DSI is not a project, it's not a pilot, it are regular service for European citizens. So the goal of introducing what has been presented by our colleague from the Commission and the other colleague from UNICOM is really to provide in the reality to European citizens the possibility of having a safe dispensation of prescription. In the last slide, one group was not included because, of course, it's less relevant, but also the part of patient summary is touched and addressed because, of course, medication are in the prescription, but medication are also in the medication summary or the patient summary. So all what has been described here applies also to the patient summary and in future to other clinical document like hospital discharge letter, in which for sure in a discharge letter there are indication of medication performed, treatment performed, and indication of medication to be taken when they become outpatients. So it is really apart the nice thing, the good thing of working together. The important thing is to demonstrate that a project is not a project that should invent how to be sustainable. This is the clear demonstration that what we are doing as a project are already before the end of the project itself integrated. So when in UNICOM we were speaking about a pilot, okay, it will not be a pilot. It will be in the reality of the day-by-day operation of these cross-border services, a way of gradually, and I underline again, gradually take into practice the use of IDMP attributes as it was listed in the slide from Matthias, of the IDMP identifier when we will be ready. So we have not to think about sustainability. We are already building a continuity of using them, and after wave 6 there will be wave 7. So maybe we will have additional change proposal in order to make even more accurate and precise the use of IDMP, generally speaking, and in particular of attributes. For the time being, we have just using 5 attributes. Maybe in future we can add others, or we can be more precise. And so the perspective is from wave after wave after wave, even after the end of UNICOM, we will continue. What is missing? Is missing the fact that for the time being, we have very few medicinal products available. So in order to make it real, this drawing of how to cook IDMP and make a reality, eating it in the LDSI, we really need the strict cooperation, as also Robert shown, in this two, meaning one ecosystem, the ecosystem of regulator and the ecosystem of health, in which, of course, the master data derives from those are the regulator, but the user and not the final user are ourselves that we will create these services. And we absolutely need that in the process of coding medicinal product according to EMAS or procedure, this data will be made available, a very limited subset. You see the mounting, only few are needed. Maybe in the national dispensation, one element is enough, meaning the code of a medicinal product, and that's enough. No, we need more information in order to dispense safely, but these few information are really key and should come, as it was shown, from NCA through the medicinal product dictionary to the health agency that will trust those data and use those data, maybe nationally, for sure cross-border. So this is the good landscape in which we are working, in which we don't have to care about sustainability. We are already in operation. And thank you so much.
Thank you, Marcello. It's a good flashback to show us the history of the effort and also the direct impact of some of the UNICOM piece of work. And actually, that's exactly the core of today's webinar. But if we come back to the specific aspect of today's webinar, which is on semantic, and having the same semantic from the start to the end of the medicinal product supply chain. I speak not the supply chain physically, but the information chain about the medicinal product. I think this is also important to stress that some of the identifiers come from the manufacturers. They are validated by national competent authorities. They are integrated, as Robert Stichele did explain, in medicinal product dictionaries, and they continue their journey. And I think this is the deliverable 5.4 is addressing, I would say, the last part of this journey. But the first part of the journey is also important, because if you have no good data to start, you have also no good data to end, of course. So that semantic and the persistence of the information is very important to us. I don't know if we have a first question from the audience, but I suppose from the panel we may have another question. Jean Gonzague, would you perhaps?
Yes, maybe one element that has been introduced during the discussion is about the definition of the identifiers. So it's important indeed to define the medicinal product MPID, PHPID, PCID, also the substance ID. And this point has been highlighted also by Robert in terms of substance and active moiety, I would say reference substance. But on the other side, what is important is also to connect with the physical reality. And you mentioned data supply chain, Christian, but I think that the physical supply chain is also critical because it's what people will be able to leverage on when they will have drugs. People, I include patient, I include anyone that is taking a drug or anyone who is using a drug, so including HCPs. Anyone that is able to, that's the element that anyone will be able to leverage on when using a drug. And I'm thinking here the data carrier identifier in the IDMP medicinal product model, which is a way to connect from a specific physical representation, physical object, sorry, data representation going up to the medicinal product. Because the challenge of the interoperability, and I think this has been mentioned in the slide at the beginning with cross-border prescription. I think it was the very early in the very early slides. Cross-border dispensation. If I'm going tomorrow with my Belgian pack in Germany, it will be always very tricky to get the exact same drug in Germany. But we can imagine that leveraging on the physical identifier, so supply chain identifier like DCID from the pack, we can then ping back via the data, via the medicinal product dictionary to the corresponding German pack. I think this aspect doesn't need to be underestimated and is very important in the practical day-to-day implementation and use of IDMP. If we really want to leverage and to have a leverage on the data, we should also very well define this element, this physical element. So I don't know if this is triggering some reaction in my colleagues' minds or some reflections.
Thank you, Jean-Gonzague. Does someone want to react to this?
If we have an accepted PHP ID for the Belgian product, an accepted PHP ID for the German product, then it should be quite simple to make the link between two identical products. But it depends on the existence of and the correct determination of the PHP ID.
I agree with you, Robert, but the challenge is when I take a box like that of a vaccine, Tetravac, the only identifier I see on the box that I can read with any device, like my smartphone here, so it's blurred, is this data matrix, data matrix containing the global trade item identifier, lot number, what else? The serial expiry date and unique number. So this can ping back in the SPOR database to the corresponding PHP ID, MP ID, PC ID, and so on. And from that, I can go down in Germany, in France, or wherever to the same product. So I see that, José, you want to build on that.
I just no, this just gives me one quick reaction, because this is exactly one of the fundamental points of our semantic specification. So if we're looking at this and if we're seeing one identifier, the other identifier, first of all, we are clarifying what we mean by identifier. And the second thing is that there is no perfect single identifier that's going to cover everything, but by knowing what this means and how this identifier relates to the other identifiers, then we actually can solve the other use case, which is, well, the only thing I have is a barcode scanner. But it doesn't have to have the PHP ID. That was an idea that was even vehicled before. But once I know exactly what this means and how it is expressed, and then I can ask the other systems that have a whole new semantics, but it is compatible with our specifications via the IDMP, then this is the purpose of semantic specification as a whole, not for one specific silo of information.
We don't want this beautiful medicinal packages spoiled by too many dots. So I think coming back to the idea of having a portfolio of identifiers which can be addressed through one identifier, but give you the link to the different identifiers, probably to be maintained at the national level, is an important idea.
Marcello, you want to express yourself?
Yes, this is very correct, meaning it will be very correct. Because working with NCA, we discover and we discuss that for the time being, there are so many variants and variability on the way of building this identifier. So Matthias has shown that we are ready to transfer the identifier, but at the same time, remember the initial picture with the Paramount Mountain, we continue thinking the importance of describing the medicinal product, because yes, in 10 years for sure, in 5 years maybe we will be able to do what you mentioned, because we know that the same product, the same medicinal product will have more than two different PHP ID, and will be very hard to correlate them in a easy and correct way today. So we, in the cross-border environment, we put aside the idea of working with a centralized medicinal product database 7 years ago, maybe 10 years ago. We tried again with the Article 57 database, but we could not enter into operation with that. So for the time being, we remain at the point in which we continue describing in a correct way the attribute that identify a medicinal product, and leaving to a pharmacist the task as a professional to understand which is the product to be dispensed. Of course, what you are saying is our medium long-term goal, meaning starting with the PHP ID, being able to get all the equivalent medicinal product, great. Starting with an MP ID, come and get exactly the same medication from the same pharmaceutical company, even if the name is different, perfect. Same for PCID, but this will happen not next year, not in 2 years. And there is a learning curve by NCA to not just harmonize, but align the way in which the identifier will be generated. Otherwise, we need another database that correlates the different PHP ID for the same medicinal product, not just because one is PHP level 1, level 2, level 3, or level 4. No, because the same PHP ID level 4 are different. So this sort of correlation will be needed. And we know, because we are working with NCA, they are working in order to come to this uniform way of behaving, but it is not something for, again, as I said, next year, 2 years, 5 years, for maybe 10 years for sure. So I agree with you, Jean Gonzague, that is important to keep this in mind. Thank you, Matthias, and the others that have already created a ready system to transfer this identifier when available. And it is important to start transferring this identifier as soon as possible, because if we are start exchanging, then we can even start checking and see what happens in the reality in one pharmacy in Italy or in another pharmacy in Greece or any other country. So let's start small. Let's start in a gradual, incremental way. Let's aim to what you, Jean, mentioned as a goal. That was the initial idea of UNICOM, identification of medicinal product. Remain, and we hope to be ready to describe medicinal product, because the today's situation is that we transfer textual description taken from the boxes. And this is the only way of giving information, because I don't want to enter into the detail, but yes, it is important that we understand, we improve step by step. The fact that we will adopt in wave 6 EMA SMS is already a breaking situation, meaning we will finally be able to describe the substances, the moiety, etc. So the point then will be to correlate the substance with the correct strength, reference strength, our strength, blah, 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 blah. and it is important we start working in order to build our knowledge, build awareness, keeping the trust, because we must keep the trust. Thank you so much. Sorry.
Thank you, Marcello. Yeah, we have to be visionary indeed for this.
I think we are fully aligned, Marcello. My only point here is maybe to add in this semantic work, adding DCID as one of the addition of the fourth identifier to be mastered.
Matthias showed you that the PCID is there.
PCID is not DCID. Huh?
Sorry, I did not understand. Okay, thank you.
You have a big difference between DCID and
No, I understood PCID. I beg your pardon.
Oh, sorry, maybe I mixed up. Sorry.
Okay, that's good. I propose, José, you have a short question, right?
No, it was a reaction to what Marcello was also commenting, and I think he wrapped up quite nicely.
Okay, so you don't have a question. Good.
I have a few others, but I would stimulate. I'll have a few others, but I would like also to stimulate the audience, because I think this is things that we can expect from the field as well. Like which is the best identifier? How do I use them both? I'm pretty sure we are not the only ones that have these questions, right?
Yes, indeed. That's why also we have some people having joined us today to wonder about this. But I haven't seen any question in our Q&A facility yet. So that's not promising a large debate with our audience, unfortunately. So now we have Robert van der Stichele with the hand raised.
I would like to come back to the work of assigning the correct substance, assigning the correct dose form, normalize the strength, and to do that for each of the, on average, 8,000 products in 27 member states. The idea that we must wait for the master's data to trickle down from EMA to NCAs, to dictionaries, and to vendors, it may be a little bit utopic. I think this is true for the new products, yes. And that is the system of the future, but we are stuck with the legacy conversion. And I think if we want to advance, if we want to have substantial minimal data sets for a substantial number of products in a substantial number of countries, we will need to bring on board the cooperation of the stakeholders at the national level, the dictionaries, and together with the NCAs, provide a data flow not from top down, but from bottom up to EMA for the old products, which EMA can then validate. But this elephant must be cut into pieces because he's too big to handle. I think Article 57 has proven that it has collapsed under its own weight, and there needs to be found a division of work. We need to trust the national level to play an active role in that. If everybody waits for each other, we will not get there in 5 years, not in 10 years, not in 20 years, I think.
Well, indeed, you're right. So we have a few things which are already widely implemented, and that's the famous barcode which Jean Ponzac showed us. It took us in Europe a couple of years to have that implemented, but now we have it. I think the two remaining countries are Italy and Greece, who had a longer transition period, but that transition period is nearly to its end. So we have a couple of things which exist, and I think also that EMA is and the NCA together is making huge progresses. Although the journey is long, is a rocky journey, but they are making huge progress. And if effectively we can, I would say, develop this collaborative approach for the legacy products, legacy substance as well. And I know industry is strongly engaged in supporting this. That may provide some hope for progress and not too long progress. José, you had a question.
No, there is a question.
Yes, I saw that, but maybe José, can you be brief on it and then?
So on which one? On the question from Oscar or on the question that I was also wishing to share?
Let's go on the question of Oscar because the
yeah,
time
Oscar.
is passing. So
Indeed. So
I read first the question so that everybody has seen it. One challenge is to use an identifier in the electronic prescription that captures the prescriber's intention and doesn't lose information bit that also doesn't introduce false specificity. Is there work related to identify national variations in product catalog for prescribing? Question mark.
Oscar, this is an excellent question to the point that we have been trying to make. So yeah, on one hand, if you have a very generic identifier like a PHP ID, then you risk losing some information. If you have a very over-specific, if you force an over-specific identifier, then you are introducing what you are calling false specificity. And this is linked to what Marcello was saying, is that we are not looking only into the identifiers and what they mean, but also the attributes that describe the medication. So if you need to describe the package size or any of the excipients, like do this but without lactose, etc., you can do this with a common specified language without reducing that language to a bunch of identifiers, because no matter how good your identifier system is, it works for a specific context. In the supply chain, you want things very specific. In the prescribing world, you want to have some ambiguity because prescription does have those levels of selection of what you want to prescribe. And in the regulatory world, you really want to have specific. So this is one of the fundamental questions that we have to ask, that we have been asking ourselves. There is a risk, and the way to handle that risk is not to rely only on what is the perfect identifier, but also to complement that information with the attributes that Marcello mentioned.
Yeah, thank you. Perhaps I saw a comment from the chat box also. Why not having the top 10 medicinal products with the full information on it? And that is a good question to just mention that at UNICOM, we are working on a so-called pilot project list. And that is supposed, that has the intention to provide perhaps not the information for the top 10, but for a representative quantity of medicinal product so that we can make these exchanges. Having the top 10 for the operations, which may be what Matthias was thinking at, having this, certainly we can conceive that and talk about that and work on that. But I think the first step is to have this pilot product list, because really we have to learn first with the practical aspects. Robert van der Stichele wanted to answer or comment what was just said.
Yeah, Jean Gonzague suggested also the role of the industry. And I think, yes, in the legacy conversion, especially when we go into pharmacoarchaeology and have to dive deep into into historic documents to know exactly how this particular brand was formulated, I think the help of the industry will be crucial. But on the slides, we put the pharma headquarters at the supranational level, but indeed they will play a role at the national level too.
Okay, you know, there are 3 minutes left. And Marcello, you have 2 minutes of these.
Oh, okay, I will be very short this time. Oscar, you remember that in the prescription we have a flag is substitution allowed or not allowed, and we must be very clear with pharmacies that even if a PC ID is given to identify a specific packaged medicinal product, they are free to substitute it with an equivalent one. And here comes a point that was risen in open medicine, saying we need a new identifier that is a sort of generic packaged medicinal product in which the manufacturer is not included, but other information are included into it. And this was one of the output of the open medicine. Second, answer to, I don't remember who made that, but we are not aiming to a top-down approach from EMA to national ACA, not at all, because the process of sport is NCA provide the data to EMA through the specified FAR interfaces, etc. So it is not that we are waiting for the data for every medicinal product to be provided by EMA to NCA, but on the other side, EMA and sport to define the code system and the value set, and NCA and others to adopt the value set to describe their own medicinal products. So of course, the first one will be, as it was said, the new medicinal product, fine, but it is a task over the NCA also to code the other medicinal product. And of course, now there is another element. The same product present in several member states, the NCA should lies in order to not duplicate the activity, but agree on a sharing of activities. And in this way, we will have a multiplication effect of working together. Thank you.
Thank you, Marcello. Actually, the purpose today is not to speak about, say, EMA and SPOR, but mostly to say that the information which you in this deliverable have pointed at as this common semantic along the processes, that information is very important. We understand that it must come from somewhere, and there are many players who provide information for that. This semantic continuity makes that it starts on the left of my screen, if you want so, at the manufacturers. It passes through validation, dissemination, etc. And at the end, of course, at the use. And it's a great achievement, I would say, or great step. It's not an achievement, it's a step. That EHDSI has the purpose now to integrate a couple of these identifiers to enrich what is carried, is it in electronic prescription or patient summaries, etc. So that's the purpose of today, to learn about this. It is now the top of the bottom of my hour, so I think it's time to come to a conclusion, and I try to summarize a little bit what we said. It is my duty also to thank all the speakers and panelists for having joined us and share their enthusiasm in this conversation. It is really an important point that we understand in common how the picture behind my head here works in practical situation and impacts not only the regulatory space, but also the clinical space and more in the later supply chain. With this, I want to close the webinar, the Committee of Expertise. Again, thank you for our attendance, and I wish you good health and also a good weekend ahead of you. Goodbye.
Thank you. Bye.
Thank you. Bye-bye.
Thank you.
Thank you. Bye.